Caesar Rodney Square in beautiful downtown Wilmington, Delaware.
We are the Podcast Pediatricians. And it is beautiful today, Rob, isn't it? I'm Matt Gotthold.
And I'm Rob Walter. Check us out on Facebook and at podcastpediatricians.com. And yes, we're back and we're not wearing masks.
Woohoo!
CDC says...
We don't believe in that coronavirus stuff.
But if you're vaccinated
Yes.
and just a few people, so that will open things up. You always worry that someone's going to take off and run with that, like, you know, Texas and Mississippi saying, like, everything's fine now.
Oh, my. What, boy.
I'm sorry, idiots.
I'll tell you. Neanderthal thinking.
Yes. I like that. He probably didn't write that line, but I did appreciate it.
That was Joe being a little bit more reserved than he's known to be in the past, but still making the point.
Yes. So welcome to today's episode where we finally discuss ADHD, attention deficit hyperactivity disorder, or if you're a stickler, just ADD when a person does not have the hyperactivity part. Now, this is a huge topic, and there's no way we can do it justice in just one or two episodes. But, you know, that's never stopped us before, has it?
No, it has not.
Not at all. So we'll do an overview of the 2019 AAP guidelines on ADHD, concentrate on what we have to offer, which is tips on diagnosis, pearls, and navigating the rough seas of discussing this diagnosis with patients and especially parents, and hopefully some sage advice on treatments for ADHD. Certainly in this COVID pandemic, with its social isolation and its too often virtual educational experiences, there has really been a challenge for many kids with ADHD. We're getting tons of calls from parents about focus concerns in their children, along with increased levels of anxiety and depression. Often all of these concerns are happening at the same time, so it's difficult to sort it out and decide where to start when trying to help these families and kids. For many of these kids, sitting in front of a screen all day is just torture, and it disproportionately affects the public school kids, at least in our area, since most of the private schools stayed almost completely open during the pandemic. And as we said before in this podcast and in the local media back in early July, we must get kids who generally have an innate natural immunity against the novel coronavirus back in school. And yes, that includes prioritizing teachers for vaccine doses along the same lines as we prioritize senior citizens and really ramping up COVID testing in schools. We should put the same type of effort towards getting schools open as has been put forth for non-educational entertainment, especially professional sports. And who better qualified to talk about ADHD than two guys who kind of have it themselves? Now, we may not have been formally diagnosed. Matt, have you been formally diagnosed?
I have.
Okay. But we both have become familiar with being perceived as having very short attention spans and being very impulsive. Yes, Matt?
Yeah. Yes, people have been mentioning my ADHD tendencies for much of my life, including my wife, who has known me since kindergarten. We quickly noticed early on when Rob and I met that both of us seemed to keep to-do lists in our pockets. In fact, I have one right now.
Me too.
Because we forget things, and then we inevitably lose our to-do lists.
Isn't that the worst?
I will make multiple copies of the same to-do list.
I take a picture of my to-do list with my phone in the middle of the day, and hopefully I won't lose my phone.
For sure. Yeah. Hopefully we might be examples that a little ADD can, on some levels, be a positive thing.
Maybe.
Yeah, maybe. That is often what we tell our parents, our own families, and ourselves, you know, when we're trying to justify some of the ways that we behave,
because
right?
We're great.
Well, you said it. ADHD can be, though, and Rob has alluded to it, a superpower if it's channeled in the appropriate way. And with the appropriately placed, I consider it to be guardrails, like almost like when you're bowling as a kid and you have those little rails on the side, so you don't.
Those.
That's right. So you don't go in the gutter. Many of those who are affected have huge amounts of energy and, paradoxically, the ability to hyper-focus and perseverate on one topic for a long time. Parents often see this ability as being proof that their child does not have ADHD, and it can be perceived as being stubborn by some parents and families and teachers. But those with ADHD sometimes have a difficult time shifting their attention to new tasks or conversations when parents or teachers ask them to do so because they're so perseverative on what they're doing. ADHD often presents as that old adage, his teacher says she thinks he has ADHD. But then why can he play like zombie apocalypse at the OK Corral for 10 hours straight, huh? Riddle me that, doctor, right?
He must be lazy.
Absolutely, right?
And again, I'm pretty bad, but Matt does take the whole thing to an entirely new level. He forgets his wallet, his glasses, his list, like every single podcast taping. He's heavily invested in tile because he needs it pretty much every day. I have thought about maybe crazy gluing a tile to his forehead so we can keep track of him.
In fact, for those of you who don't know what tile is, so it's this essentially like geolocator. So it doesn't necessarily act at great distances unless other people in that area have the tile app. And so it bounces around and it can help you find things. And so I have indeed lost a wallet at a gas station. Actually, it was probably on Route 13 outside of a gas station and never found it. I lost my iPhone once, and where did we find it? Only with the help of Find My Eye and my iPad in the middle of a median strip on that same Route 13. And my son and I looked at each other like, we're not even going to try to explain how this got here. Everything that I own, I try to make red so that my staff and my family and friends know that if something's laying around that's red, it's probably mine. But if you're looking for a deep dive into the detailed nuances of making the diagnosis of ADHD, then you should probably skip this podcast. But if you want to hear real-world, gut-wrenching, right in the middle of it experiences accumulated from over 50 years between us of both diagnosing and, at least for me, experiencing ADHD, then stay tuned. But so you don't think that we're just winging it, much of the information we'll discuss today has been gleaned from the Academy of Pediatrics 2019 Clinical Practice Guideline, which we mentioned a minute ago, as well as from the AAP's supplement on ADHD, which was published later that same year, and which added some real-life scenarios. I think this was the first time the AAP tried to address some of the common obstacles to care in the form of actually an extra supplement, at least for ADHD. There was also an excellent virtual talk during the recent AAP annual meeting, which spoke to adopting and incorporating the AAP's clinical guidelines within a pediatric practice. This talk was given by Dr. Joe Hagan from Burlington, Vermont, woohoo, Vermont, who is just an ideal model for the complete office pediatrician. He fully advocates that we office pediatricians can do it all when it comes to ADHD diagnosis and treatment, but, as we will discuss, maybe we are not as enthusiastic about doing it all as he is, because sometimes it gets a little complicated.
It does, and full disclosure, we will liberally borrow medication tips during this discussion from a talk by Dr. James McGough, a psychiatrist from UCLA, and also from Up to Date, as well as some good articles from Contemporary Pediatrics, especially one by Dr. Harlan Gephardt, as well as some pointers about psychoeducational testing from Dr. Susan Andor. And as always, anything we say that is wrong is completely on us and not any of them, because they are excellent and we are less so. So, Maddie, hit me with a disclaimer.
All righty. We are sharing our own personal opinions on pediatric care. Always talk to your own pediatric caregiver about your child. Pediatric caregivers should always consult expert guidelines and consider their own community standards of care.
So it's been a while since our last podcast. It was way back in 2020, and we're both glad to put that year behind us. Ooh. The highlight of 2021 so far was Matt's epic Coit, whiskey and fire pit extravaganza. So what are coits, Matt, and why did I suck at it so much?
Those are actually two different questions, aren't they, Rob? That was so easy to kind of pick off. You threw me a softball on that one. But what has always been an important part of the Gotthold family traditions is we play with metal quaits, believed to be originated, at least by my family, out somewhere in the Pennsylvania Dutchish area. I'm kind of German-Irish extraction. And so my great-uncles would play this game where you take this round metal object. It's a ring, absolutely. That is a little bit concave on one side and a little bit convex on the other. And just like horseshoes, they're labeled like there are two A's and there are two B's. And you stand about 21 feet apart. The pegs are 21 feet apart, and they're the height of one of these quaits. And quaits are anywhere from, say, 4.5 inches to 6 inches. We like to play with the smaller ones.
And they're heavy.
More of a challenge. And they are heavy. They're heavy like a horseshoe. And so it takes more than a little effort to throw them accurately. And the beauty of them is because there are these kind of nuanced implications to the way the quait is shaped. It's kind of like half of a flying saucer. You can do unusual things with them if you get used to it. Like you can skirt one over the other to try to get it on the ring. If the first one is in front of it, you throw it upside down, and it moves that way. So it's something that like even people like Rob can enjoy.
Yeah. And you can spin them almost like a frisbee.
You can
if you're
do that.
good at it.
Yep.
You get these little
My son likes to throw them like
Curveballs.
that. I like to throw them kind of dead weight, almost like a knuckleball, so it doesn't move at all. But it has provided just endless fun competition, conviviality at our family picnics for the last, probably since 50 years plus.
Especially he had some ginger and Jack, and
We
and fire. Who doesn't want fire pits?
We introduced Rob to Jack and Ginger. It's apparently something he'd never experienced before. Although we'll get into his family's favorite drink in a minute or so here.
Yes,
but no, I was looking for something that could get my buddies together and would be able to be safe for us being outside. And it was freezing cold, so I had some fire pits, and we just had a good old time, I think.
Let's start with a little COVID stuff first. And right now, of course, when you talk about COVID, you're talking about vaccines. And Matt and I both got vaccinated last month with a Moderna vaccine. And the fact that it was Moderna was only because that's what was offered to us. Pfizer would have been just fine. And remember, when people toss around efficacy numbers like 95% or 72%, these percentages are all still insanely high compared to the usual 40 to 60% for a given year's flu shot. I also think that the new single-dose Johnson & Johnson vaccine from New Jersey,
Jersey,
will be huge. One shot, and it can stay in a regular refrigerator for months. People are just making too much of the efficacy of 72% versus the 95% for the others. The trials for the J&J vaccine were done later during a COVID surge, when Moderna and Pfizer's trials were done during a lull. So with a lot more cases around when they did J&J, it's obvious and predictable that the efficacy would be a little bit lower. If they had done Moderna and Pfizer later, it would have been probably in the 70s too. And again, 72 is spectacular for a vaccine.
This type of a seasonal one at least, or
Right.
one that mutates.
Right.
Yeah, for sure.
The most important thing to remember is that every COVID-19 vaccine so far has been 100% effective against death and almost 100% against hospitalization, and that's what really matters. Now, I've seen some pushback on that, and to be totally honest, the 100% comes from the original sample size, and it didn't include the uber elderly or maybe people with many risk factors. So we know that there will be some people eventually who get the vaccine who succumb to the disease, but that's going to be rare, and pretty much getting the vaccine will make it so you won't have that bad outcome. And Matt, did you have any bad vaccine reactions?
No, and I think both of us have gotten 2 doses, so we're both fully vaccinated at this point. And honestly, the only experience I had with either time was it felt like somebody gave me a little knuckle noogie, in my arm, like any other vaccine. Now, having said that, my sister-in-law had a horrible reaction the second time she got her vaccine, and she was down and out for an entire weekend.
Right, so
just feeling flu-like.
And after my first one, just a little arm soreness. After the second shot, I was achy for a day and a little fever. So not as bad as what you're describing, but certainly worth it. And it's been interesting anecdotally, I don't know if you've heard this or seen this, that it seems like the older you are, sometimes the less of a reaction you get. Like I've talked to even my mom who's 88 and some people who are in their upper 70s, 80s. Many have said they didn't get much of a reaction. You always want to get some kind of reaction. So you're saying like, okay, did I get the real thing? So I like it when someone says, their arm gets a little bit sore. And everyone also needs to realize that, yes, reinfection is possible. And yes, you can get infected even if you're vaccinated. And we had a case of one of our people in the office who got infected a few weeks after their second vaccination. So it's possible, but it likely won't be severe. And again, masking and social distancing are still key to defeating this pandemic.
Yeah, double masking, perhaps with a surgical mask against your face and a cloth over that if possible, also still seems to be a really good and perhaps the best approach to masking. Rob, there does seem to be a race to get as many people vaccinated as possible before variants such as the B117 that has been dominant in the UK and which seems to be a bit more lethal, and the B1351 strains from South Africa, which seems to be more contagious, and the newest and scariest P1 variant in Brazil that seems to reinfect people more often. All these may start to become more and more dominant. To date, the vaccines which have been approved still seem to be effective against these new strains in preventing severe COVID disease. So that's a comfort for the time being. But with these variants, we may more likely need booster vaccines in a year or two, largely meant to cover these COVID variants more effectively, similar to what we need to do with the flu vaccine. As everyone knows, that changes every year based on what we're seeing or what is anticipated, at least in the community. Still, the faster we can get people vaccinated, and then if that's in play, the less chance there is for variants to evolve and to become dominant.
And vaccine trials for kids are underway. Most of the trials involve younger teenagers. I think it's 12 and above. By the time they're all completed, it looks like we probably won't be vaccinating the teenagers until late fall 2021 or even into early winter 2022, and then the younger kids after that. Just this week, the AAP came out strongly urging Big Pharma to really step up their pace on kid COVID vaccine trials, even below age 12, and we strongly agree with that. It is likely that we'll be giving COVID vaccines pretty soon to some of our older patients over 16 or over 18 with high-risk conditions like lung, heart, and other chronic diseases. In our office, we had one extra dose left over last month after we vaccinated our office staff, and we called up a college kid we had who was 22, had cystic fibrosis, and we were happy to get him vaccinated. I was originally hoping that things would be a little bit quicker, that we'd start to do all the kids by the summer to say, let's get them back in school. But it really doesn't seem realistic given that they have to go through the safety trials.
Right.
And we want them to do that. But as we've said before, the schools should open up regardless if all the kids get vaccinated, with everyone masking and distancing, and get all the teachers vaccinated. And just this week, Delaware finally said, yes, all the teachers should be vaccinated, just like the senior citizens. They should have done that before.
Getting vaccines to kids will be crucial on multiple levels, likely starting with the teens. Teens are at higher risk than tweens, who are at higher risk than the younger children. The innate immunity that children have seems to wane with age. However, even teenagers are at much lower risk for significant COVID disease than are older adults. Of the almost 500,000 deaths from COVID in the U.S., less than 300 were children. Most of them were teens with pre-existing conditions that put them at particularly high risk. So, children are not zero risk, but they are at really, really low risk for severe, life-threatening COVID disease. Yet vaccinating children will be integrally important to getting us out of the grip of the pandemic. With estimates of needing about 80% of the population to be vaccinated to achieve herd immunity, having children vaccinated is critical since they account for about 25% of our population. Because of this, even if we were to vaccinate every single adult in the U.S., there would still not be enough of the population vaccinated to achieve herd immunity. We still need to vaccinate children. And since there is still a large part of the country who are vaccine averse or vaccine hesitant, it means that vaccinating children will be crucial.
However, I imagine some parents thinking that since the kids are at lower risk for serious complications from COVID, that they would prefer to take their chances and not vaccinate their children, especially if they perceive there could be side effects and if both the parents and the grandparents have already been vaccinated. So it'll take a lot of our pediatric skills to explain to parents the advantages of having their kids vaccinated, including the advantage that it brings to the child's parents, grandparents, other loved ones, and the overall community, our human community, our country, the world as a whole. As it stands now, we probably won't get back to regular normal way of life until at least 2022, but much of that assumption is contingent on acquiring a herd immunity type of status.
Which brings us to the other big issue that's part of the vaccine situation, the way that the vaccines are being distributed. Distributing vaccines is a logistical challenge, and inevitably there will be logistical snafus, like what happened in Philly when a 22-year-old Drexel student with absolutely no healthcare experience started a company called Philly Fighting COVID, sure sounded good, and received a huge contract from the Department of Health. Unfortunately, the vaccine his company received was not prioritized for high-risk citizens in the public the way it should have been, but was instead given to his buddies. Yikes. But these things happen in Philly.
Bad things happen in Philly.
I've heard that somewhere before. We were lucky that two of our local hospitals were able to provide the vaccine to us in the community as pediatricians pretty early on. However, it was harder for some of us to get our nurse practitioners, our PAs, and other staff members vaccinated. There are different protocols being used all over the country and are even different guidelines within a given state. Our practice was able to get our staff vaccinated through the local children's hospital. And Rob, I think you ended up getting some vaccine into your office for staff from the Department of Public Health, is
Right.
that right?
That's what we did.
Yeah. So it was understandable that most of the vaccine was distributed to large hospital systems first, but this fact did leave a bit of a blind spot for the independent caregivers and healthcare workers out there.
Yes, it did.
It surely did. Some of the independent ENTs and primary caregivers in our community have reached out to vaccinate local psychologists, dentists, and other independent health caregivers. We are hopeful that with a new administration in Washington, there will be more uniform guidelines for vaccinations and for testing as we move forward.
Which brings up another conversation we were having a lot in the office about vaccine hesitancy surrounding COVID-19 vaccines. And I've started to proactively ask parents at just about every visit, well or sick, if they are considering getting the vaccine for themselves. I think we pediatricians are considered very trustworthy when giving advice about health issues for the family. And if we can help families make a more informed choice, as long as we don't logic bash them in terms of, if they're hesitant to kind of say, you're an idiot, I think we have a good role. And we can use our inherent pediatrician motivational interviewing skills when we discuss vaccine. We should calmly ask families why they're hesitant in the vaccine, have that conversation that's not judgmental. If they mention that they feel the vaccine was rushed, we can point out that the greatest factors in time are usually getting enough money and also getting volunteers to do trials. And in this case, each company got $1 billion and tens of thousands of people volunteered in the first day. And these are the most important reasons why the timeline was so dramatically shortened. Plus, the companies enlisted by the U.S. completed all phase 1, 2, and 3 safety trials for any COVID-19 vaccine that was approved. This was not the case for vaccines developed by some of the other countries, specifically Russia and China.
Some parents may mention that we don't have an experience that is over a multi-year period with vaccines that are based on newer technologies like the mRNA-based vaccines that we've discussed before. We should acknowledge this and agree that this is true, and in the same conversation point out that this mRNA type of technology does not get into the nucleus of the muscle cells of the tissue into which it's injected. It only inserts into the cytoplasm, and over time it will be washed out. There's no evidence or inference based on the research done that the mRNA can have long-term effects. It's important to acknowledge the parent's fear, but then invoke science to make a convincing case for the use of these vaccines, which we can pretty much agree on. Those of us, at least in our pediatric circles, are very safe. The Johnson & Johnson vaccine uses more traditional vector-based vaccine technology. This type of vaccine may be more acceptable to people who are leery about the mRNA type of vaccine. When parents are still hesitant, some of us will ask if they want their parents, the grandparents, to get the vaccine. Often they'll say yes, and say that since the grandparents are older and at higher risk for succumbing to the virus, that they're more comfortable. These types of conversations at least open the door for further discussion, including the fact that the child getting the vaccine helps to protect their grandparents.
Another common question concerns COVID-19 vaccines for pregnant and breastfeeding moms. And this is a question that's been a bit controversial, but I think the information has been a bit misinterpreted by many. The WHO World Health Organization put out a confusing, poorly considered statement weeks ago, which seemed to say that pregnant women should not get the vaccine, inferring it would be dangerous. In fact, what they really should have said was that there's been no studies on the effects of the vaccine while pregnant or breastfeeding. I tell pregnant moms that they should discuss it with their obstetricians, who I think are more on top of this than most of us pediatricians. But when I look at the literature available, my feeling is that since pregnant women do have a higher rate of COVID-19 complications than non-pregnant women, the benefits likely outweigh the theoretical risk for most pregnant women. Now, for breastfeeding, I think it's a lot clearer that it makes sense to get vaccinated, since the antibodies developed due to the vaccine will help protect the baby, and multiple studies are now showing that the antibodies do get in the breast milk. And we know that in the year after having a baby, moms are at higher risk for any infectious problems, since having a baby depletes the mom's immune system. This is one of the reasons why it's so important for new moms or moms-to-be to get the flu shot.
And speaking of the flu shot, we're still encouraging them, but as we mentioned many months ago, there was no notable flu in the southern hemisphere during our hemisphere's summer, so we are seeing one of the mildest flu seasons ever recorded. This was predictable, but it seems that some epidemiologists and other experts were surprised by this. It was also the argument made by some of us that it was potentially even more important to be vaccinated for the flu this year, since a flu-COVID combined infectious state was a recipe for disaster.
The twindemic.
Indeed. So many variables, but fortunately, this has not developed.
Now, I did have my first RSV admission, and baby was pretty sick and did fine. The ER was kind of excited, though, like, we got an RSV, because, like, it was the first one, which is just so bizarre because kids are so healthy.
Yeah. Remember that company that we discussed last year that developed a new single-dose flu pill?
Oh, the Zofluza.
Mm-hmm. They have been pouring money into ads this season, but there's no flu.
I see that.
To use it to prevent.
Yeah, it kind of sucks for them.
Yeah, it does. Yeah. But by no means is this meant in any way to discourage people from getting flu vaccines in the future. They save millions of lives. But this year, however, it seems like it was simply good insurance, which is never a bad idea.
And lastly, there has been an uptick in the scary multi-system inflammatory syndrome in children, also known as MISC, that we detailed in early COVID podcasts in the past. I had my first patient with this last month. It might have also been a typical Kawasaki. There was overlap, didn't fit all the criteria, but because it was such a young child, it was an infant, and they have higher risks of cardiac problems, no one took any chances. They got the full IVIG plus steroids, and the kid's doing great. But as we're seeing in the literature, since there's a bit of a surge around Christmas, we're seeing more MISC. And still, as much as we say kids have innate immunity, we still have to be vigilant.
We also talked about some of the pandemic-related pediatric issues that have skewed upward, such as the increase in toxic ingestions and in at-home injuries. With many at home and with increased antimicrobial measures in place, it's no real surprise that the number one child ingestion now, accounting for up to 40% of child ingestions in 2020,
drum roll,
is of hand sanitizers. The big potential danger here is due to the alcohol in most of them. Most of these kids are fine since they just taste or lick the sanitizer. But if they drink a fair amount, then they can get dangerously intoxicated, since the sanitizers are routinely anywhere between 60 to 95% alcohol.
Wow.
This makes them stronger than most hard liquors. Sanitizer and ginger? I don't know.
Okay, so speaking of hard liquor, Maddie, have you ever had a vodka Negroni?
No.
Okay, well, maybe that's a good thing. So it was my late dad's favorite drink. It's got vodka, vermouth, and Campari. And his birthday was last month, so I got all those ingredients. Wasn't easy to find the Campari, and made it. And I made one for you today. So take a little swig there, Maddie. A little red look.
The glint in your eye tells me this may be a dubious adventure.
It's a perfect vodka Negroni.
Oh man, that's nasty.
I know.
Oh, it tastes like you can imagine like mud would like it's like bleh.
It's bitter. You know, growing up, my dad's like, "What do you drink?" He said, "Try it." He would always be like, "Dad, that's the most disgusting drink I've ever drank in my life."
Bitter. Like I'm a fan of like gin and IPAs, but this is nasty.
So I decided every year on his birthday,
I'm going to finish it.
No, you don't. Drink that nasty vodka Negroni.
Okay, we have to mention it, Rob. What do you think of the Carson Wentz trade to Indianapolis and the new coach of the Eagles?
Oh my God, it's really tough. I mean, I was all in on Carson Wentz being an elite quarterback of the future. I even bought a really expensive Carson Wentz jersey if anybody wants to buy that from me. But man, he really stunk it up this year, even though he had no offensive line and didn't have a lot of tools. And there seemed to be, most importantly, locker room issues. So I'm at peace with it. Go Jalen Hurts. Looks like we're going to lose Zach Ertz too. What do you think of losing Wentz?
I like you. I think that you put it very well. I'm at peace with it. I think that it was an irreconcilable difference, from the standpoint of the way things are moving. And I thought it was only going to continue this year if they tried to do anything else. But I can tell you, my son Justin, he is a huge Wentz fan, and he's a pretty savvy sports spectator.
Right.
So he's thinking about switching his allegiances. I mean, he feels that strongly about it, which will never happen. At least if he wants, if he wants his father's season tickets down the road.
I know, and we're Eagles fans, so we're braced for the fact that Carson Wentz will get 5 Super Bowl rings with the Colts, and we'll be like killing ourselves. But
hey, if you talked to us, 3 years ago, We were just loving this guy.
I know.
And I just don't know what happened.
1 year ago. I don't know.
Right?
I know. So as for the new Eagles coach, Nick Sirianni, I don't know that much about him. He had a terrible first news conference. I've heard some good things. The strongest opinion that I've heard about Coach Sirianni was actually from my Uber Eagle fan nurses, triage nurses, Megan and Janet, and they really, really like him because they feel that he's a hottie. So I guess that even if the Eagles suck for a while, at least our coach is hot.
This is one of the few times I really don't have any reply.
Oh.
All right,
That's
so
just what
let's
they
move on.
said. That's all I'm just reporting it.
So on that note, you can see that once again, we're not focusing enough on the topic at hand, which is ADHD. We'll be right back with our ADHD extravaganza.
But first, our sponsors.
So as we usually do, we have to send out some love to Julie Ortiz, who runs a wonderful business called Triage for Pediatrics. These are the folks who handle all of our phone calls in the evening times after we decide that it's time, which for us is at 11 o'clock. What do you do, Rob?
11.
Yeah. Believe me, I'm thinking about moving it up. The older I get, in any event, so just phenomenal job. We've never, ever had any issues with these people. They're seamless. They're polite. They're good to our patients, and they appreciate it. So rock on, Julie. And if you are interested in acquiring Julie's services or looking into it, it is Julie Ortiz, Triage for Pediatrics. Phone number is 214-450-5030.
And also Jim Hansen of High Fives Incorporated. That's HI5S.com, who will handle all of your IT needs. He does PHP programming, MySQL database development. I never know what that means. System administration, security, especially these days, and the ultimate firewall. Just call in the Marine, and he's just great. Great customer service. And his number is 877-483-1040, extension 1. That's highfives.com.
We are back. ADHD, attention deficit hyperactivity disorder, was first mentioned by a British pediatrician in 1902 as an abnormal defect of moral control in children. Whew, that's heavy. This was mostly a description of the hyperactive subtype, which harkened back to the English proverb that children should be seen and not heard, from a 15th century clergyman named John Merck. Children were allowed to be present during a conversation, but were not allowed to speak unless they were spoken to. And oh boy, young kids with ADHD are heard a lot and seen generally bouncing off walls.
Right.
In 1947, ADHD was referred to as the, quote, minimal brain damage syndrome, unquote, which has surely helped to fuel the negative connotations about ADHD that still exist.
Yeah, that was awful.
Just
minimal
some
brain
of the way
damage
that this
syndrome.
was, yeah.
God.
So you're just kind of
brain damage.
In 1968, the behavior was termed the hyperkinetic syndrome of childhood in the DSM-3. In 1980, that term was changed to ADD. Regardless of what it's called, ADHD is really common. It's by far the number one neurobehavioral disorder of childhood. Worldwide, 7.2% of children have this condition. In the United States, this number is reported to be somewhat higher. Around 8.4% of 2-year-olds to 17-year-olds are believed to have this diagnosis. This represents a 5.4 million count of American children.
Wow.
About 2/3 of these children are prescribed medication, and about half receive or have received some type of behavioral treatment for their ADHD. However, 25% of children in the U.S. with ADHD receive neither medication or behavioral treatment. The median age of diagnosis of ADHD in the U.S. is 7 years old, and twice as many boys than girls are diagnosed with ADHD. Over half of the children with ADHD were first diagnosed by their primary care clinicians, usually a pediatrician. The sheer number of these children, 5.4 million in the U.S., is way too many for the mental health system in our country to manage alone.
So, quoting the AP guidelines, the primary care clinician should initiate an evaluation for ADHD for any child age 4 through 18 who presents with academic or behavioral problems and symptoms of inattention, hyperactivity, or impulsivity. So yes, absolutely. But again, I'm not sure that most of us pediatricians want to always be the ones who definitively diagnose it. And we can't talk about ADHD without mentioning the DSM-5 criteria for ADHD, which is broken down into 3 subtypes: the ADHD inattentive subtype, the ADHD hyperactive and impulsive subtype, and the combined subtype with both inattentiveness and hyperactivity. There's also the ADHD other or unspecified, which usually means the child falls just short of meeting the formal criteria. There are 9 behaviors to look for in each subtype, and if there are 6 or more of the 9, then the child is considered to have that diagnosis if these behaviors are affecting performance and seen in more than one setting. 6 out of 9 behaviors are needed for younger children, but for 17 and older, only 5 of the 9 are needed to make the diagnosis. And we know that as children get older, the hyperactive and impulsive symptoms tend to decline, while the inattentiveness symptoms tend to persist.
So these are the 9 items on the inattentive list: careless mistakes, lacking attention to details, lacking sustained attention in tasks or play activities, poor listening, even in the absence of obvious distraction, failing to follow through on tasks or instructions, difficulties in organization, time management, and deadlines, avoiding tasks requiring sustained mental effort, losing things necessary for tasks or activities, easily distracted, forgetful in daily activities.
You got it, Matt. You got him. 9 out of 9.
All those kind of sound familiar, don't they?
I've been making out your Vanderbilt as we speak.
I know. It's 3s across the board. The big 9 behaviors in the realm of hyperactivity and impulsivity are: fidgets with hands and feet or squirms in seat, leaves seat when remaining in seat is expected, excessive running or climbing or feeling restless, difficulty with quiet or leisure activities, often on the go, acting as if driven by a motor, excessive talking, blurts out answers before questions are even completed, difficulty waiting turn, often interrupts or intrudes on others. So you might justifiably ask, isn't all this pretty subjective? And the answer is yes. And if you want or don't want your child to be diagnosed with ADHD, it's pretty obvious what answers to give. You can game the system more or less. And rating scales like Vanderbilt's or Connor's that we will touch on do not diagnose ADHD. They simply document symptoms, and they're a tool.
And someday we might have some affordable kind of test, maybe a functional MRI for ADHD. But for now, much is based on these subjective screenings, hopefully from all the caregivers and key teachers or coaches involved with the child. And as we will discuss later, there are tools available to look at the whole picture, best used by skilled examiners as part of a full psychoeducational evaluation. Classically, symptoms of ADHD are supposed to start before age 12, but allowances are made if some things aren't recognized until later than that, especially in children who fall in the inattentive type of ADHD. And this is often the case with girls. Many kids with ADHD struggle in particular with handwriting as they get older, and many have poor fine motor skills. How's your handwriting, Matt? Especially your cursive. Mine's terrible.
Not great.
Horrible.
I think yours might be worse than mine.
It is. Yeah. It is. Mine's atrocious, and I also can't type, so I'm a complete mess.
Same.
So again, we should be looking for things like these in children and adolescents from 4 to 18 years of age who present with any academic or behavioral problems, particularly that could be described generally as inattention, hyperactivity, or impulsivity, but also, most crucially, we should be screening for common comorbidities like anxiety, depression, high-risk social situations, oppositional behavior issues, sleep issues, substance issues, and especially in my opinion, learning and language processing disorders.
Another thing to be aware of is the possibility of fetal alcohol syndrome and a history of extreme prematurity. Standardized survey tools such as the PHQ-9 and the GAD-7 surveys can be used to screen for depression, anxiety, and other mood disorders in age-appropriate patients. For older kids, a questionnaire screening for use of illicit drugs could be considered, and, oh my gosh, make sure that the child's hearing and vision are okay, and get really specific about their sleep habits. Of course, we know our families better than most, and should consider significant psychosocial issues, adverse childhood events, and even hunger issues when evaluating these children. And certainly ask about any family history of ADHD. It runs really strongly in many families, whether diagnosed or not. It's not uncommon to review questionnaires or evaluations with parents when one, and it's usually the mom, says to the other, usually the dad, that sounds exactly like you. To which the dad simply shrugs and smiles and says, yup. If there is an ADHD diagnosis in a close family member, especially a parent, it's important to ask which medications, if any, were trialed and which, if any, were successful. So, how does the consideration of ADHD usually start in our offices? It's usually one of two ways. The mom, and usually it's the mom, calls the office and says that their child is struggling in school and that the teacher mentioned focus issues. Or, during the yearly well visit, when we should always ask about school performance, a problem gets mentioned. The first scenario is logistically easier since the family is coming to see us specifically with that concern. The second is more subtle, but often more crucial, since ADHD or a learning issue or other source of academic underachievement may not have been something that the parents or even the teachers may have considered. We need to be proactively looking for this type of situation.
Yeah, and often the first thing I do after history is to give the parents the Vanderbilt screening sheets. Now, these are for both mom and dad and for a few key teachers. And depending on the composition of the family, a grandparent or other caregiver, like a step-parent, may also be included. In the older adolescents in high school, there may not be a particular teacher who knows them really well, especially during this virtual COVID days that often there isn't a teacher that knows them well. So the teacher input may be of limited use. I also often will give a copy of the parent form to a teenager herself to fill out with their own impressions of their own possible ADHD. Now, there are many problems with the Vanderbilt survey, and any parent, again, who wants their kids diagnosed with ADHD knows how to fill it out. And the same could be said for a teacher. I used to use the Connors form, but now I use the Vanderbilts. These are open source, they're free. Again, they're not meant as a hard, cold lock tool to diagnose ADHD or make a declaration if they have it, but it's a start. It's also, again, easy to access, easy to score. How about you, Maddie? What do you start with?
Yeah, I use a Vanderbilt, and I tell the parents, this is, let me be, abundantly clear about this. This is a tool. This is, something that we're going to use to help to point us in the right direction in terms of how to proceed with your child. I've absolutely, we alluded to it a second ago or so, had people who filled these forms out, and although the parents were convinced, as the child was as well, that the child had attention issues, it was glaringly positive for anxiety and not so much for something else. So these forms, in the best use, are able to tease apart some of these confounding diagnostic areas and be able to give us a little bit more direction in terms of, particularly different from the way pediatricians used to do this, with all due respect, which is essentially like, oh, your kid's hyper? Here's a prescription. Let me know how it goes, right? And sadly, that's the way it used to go.
And
right?
some still do that.
Yeah.
Not just pediatricians. So there are more comprehensive tools used to complement or replace these types of surveys. These are generally utilized by those who are trained in a psychoeducational testing, and we tend to leave this up to the educational experts. One of these is the BASC, Behavioral Assessment System for Children, 3rd edition. This is a much more comprehensive evaluation tool than the Vanderbilt. It has scales of inattention and hyperactivity, but also has scales covering anxiety, depression, anger control, behavioral symptoms, social skills, and functional communication. It has a teaching rating scale, a parent rating scale, and self-reporting measures for all ages from 6 through college age. It's usually administered and scored by a psychologist who is versed in education. This BASC or BASC is a much longer screening and is more complicated to game it. So if a child wanted to fake a diagnosis, it would be difficult to make the numbers come out with evaluations specific for a given diagnosis that is not consistent with reality. Now, sometimes the parents tell us that their child is gifted, but just not demonstrating their full potential with their schoolwork. So how do these parents know that their child is gifted? Well, some of them had their child tested when they were just 3 or 4 years of age, often for preschool admission, with something called a WPSI, the WPPSI, Wechsler Preschool and Primary Scale of Intelligence. Have you heard of that, Matt?
I have.
Yes. However, getting a score of 130 to 140 at 4 years old, and people say they're gifted, it really isn't predictive of a child's intelligence in the long run, since it's based on expressive language skills. So if a certain toddler is consistently being read to and is enrolled early in preschool, it may make them appear to be really advanced for their age group. since the test is nationally normalized in its scoring, so it includes kids who are not being read to or are not in a good preschool, and those kids are well behind. But eventually, those kids catch up to their more language-privileged peers a few years later. So it's probably not doing any families any favors, especially that kid, to emphasize that their child is gifted based on a test at age 4, because then years later, these families are really frustrated by the fact that their child is not at the top of the class, as is that child who's been told since they were a toddler that they're really, really gifted.
Were you told you were special, Rob?
No, in fact, my parents were quite surprised that like in 7th grade, like my grades were good. Like we always thought you were a little bit slow. So yeah.
Oh my.
Maybe it was the ADD. I'm just sitting there watching TV all day.
Yes. ADHD is an attention regulation disorder. It's not just trouble paying attention. It's also trouble shifting attention or knowing what to pay attention to or what not to pay attention to. Often children with attention regulation disorders may have sensory integration disorders, feeling overstimulated by sensations that many neurotypical children ignore or filter out. Things like bright lights or loud noises, or being annoyed by tactile sensations like the tags on clothing or the stitching at the toes of socks.
Okay, full confession. I could not stand to be in a wet bathing suit as a kid. I had to bring multiple swim trunks to the community pool in Syosset. And even now, I really only wear self-wicking shirts when it's hot because I can't stand having sweaty shirt on me. So does that make me kind of a weirdo, Matt?
You are so high maintenance. I don't know how we came across each other.
So you should ask parents about some of these sensory type things, daily things that seem to disproportionately bother the child. Other questions to ask: does your child get upset in overstimulating situations, loud parties, amusement parks, fireworks? If the parent says, oh yeah, we can't go to children's parties, then it's likely something that needs some follow-up. These kids may experience the world as an overstimulating, sometimes aggressive, sometimes scary place, and what looks like angry outbursts or temper tantrums can be something completely different: a response to overstimulation or to anxiety or to a sensory processing difficulty. These things are sometimes clues to whether a child has some difficulty with attention or has some other neurodevelopmental type of condition that could benefit from a diagnosis.
Yeah, Rob, I mean, as I was reading through your script, and let's be abundantly clear, Rob is the brains of this operation. I'm just the color.
He's the brawn.
I lift things up and put them down. Rob, I'm just the color guy, yeah. But no, as I'm reading this, it says to me like, boy, so much of this smacks of an autistic spectrum, right?
Yes.
It certainly, I mean, overstimulation. I don't like this. I don't like that. It makes you feel weird and that kind of thing. And I think maybe save for the social difficulties that autistic kids have, there's so much overlap, you know? I mean, which always begs the question, like, okay, we need to call things so that people understand what we're communicating to them. But like everybody, honestly, is their own unique, you know, neurodevelopmental makeup, right?
Right. You want to use a box, but you can't.
Yeah.
And we know with kids in the spectrum, a lot of them have ADD,
Mm-hmm.
right? How many kids do you have who are on the spectrum who are also on focus medications?
I got to tell you, Rob, just over the last year or so, I've been much more aggressive in presenting the pros and cons of helping a child with an autism focus. And I've, you know, pat on my own back here, had pretty good success with having them become a lot more in tune with their learning.
Right.
Mm-hmm. You have to go carefully, but I think as long as you're careful and as long as parents are willing to risk little but gain potentially a lot, I think it's a conversation that sometimes needs to be had.
Right, and in fact, a lot of my patients who are spectrum, we haven't mentioned the developmental pediatricians, but a lot of them are being seen by them, and they're sometimes quicker than me to say, oh yeah, let's start an ADD med and also an anxiety medication.
Absolutely.
So a lot of them are on anxiety meds, and you don't want to over-medicate, but it makes a huge difference in some of these kids.
I mean, I off the top of my head, I have at least 4 children I'm thinking of right now who just have benefited in leaps and bounds by having their anxiety and their attention, augmented. To the extent where they're not anxious and they're, I'm sorry, that was the wrong phrasing, but you know what I mean.
Yes.
Again, to make an ADHD diagnosis, the symptoms need to be in 2 or more environmental settings, which for kids would be at home and in school, or perhaps in a given social situation, or for older kids, at work. The behaviors must be negatively affecting school performance, and that's key, in order to be considered. This can be a variable measure, which makes it more difficult to discern, since for many, it may result in failing grades, although for kids who are truly gifted, it may result in merely average grades. Brighter kids who are not achieving their potential can be missed and are often really frustrated by their academic performance over multiple years. But since they're not actually failing, they may not qualify for the type of educational testing offered through the schools. Often the diagnosis is missed until high school or beyond, especially a diagnosis of ADHD, primarily inattentive type, and especially in girls. Rob, have you had this experience?
I had a child this morning, a child who's even during the virtual school and public school is doing pretty well, but she's been saying for years, it's so frustrating, I can't focus. Her mom keeps saying, but your grades are good. And today I spent a long time saying, let's try to get this looked into more. I gave the Vanderbilts. It's a financial thing, so I'm going to have to try to figure out how to do a full psychoeducational. But, you got to listen to your patient, right? And she's a teenager. She's just very frustrated. But yes, she was told by someone if they request it, the school has to do it. But my experience is that if your grades are good, that you're not going to get an evaluation from the school. And as we'll talk about, schools really will make the diagnosis anyway. How about you?
Yeah, no, and I even with my own experience, I don't know if you experienced this or not, you tend to catch on to things more quickly than I do, but I would find that I could do the work, but it would take me probably 3 times longer than people who I felt like were my peers, academically. And I just had to muscle through it just because I was so distractible.
And that's so frustrating, right? You're working twice as hard. That's what I hear them saying. I'm working twice as hard just to do well.
Yes.
And this one girl today said, even if I don't go down the road, if someone tells me I have some ADD, it's important for me to kind of validate my feelings.
Yes.
And so I think we have to listen to that, even if their grades are okay. So truly gifted kids often have a high level of physical activity, low impulse control, and can be emotionally sensitive with trouble relating to their peers. Kids with learning disabilities often have behavior problems in the class, often become the class clown, and may seem spacey and have trouble paying attention and don't do their homework. But the same could be said for kids with language processing disorders who have difficulty paying attention or understanding information when things are presented to them in an auditory format. So they don't really follow discussions well, and they often keep saying, what? Right, Matt?
What?
So if we haven't made it abundantly clear, this is all very complicated. And it's particularly important to identify kids with language processing disorders early on because you want to get them to start therapy before they go too far along in school, or they may never be able to reach their potential. You can see that there can be tremendous overlap of symptoms between kids with ADHD, kids with learning issues, kids with language processing disorders, kids with emotional or psychological distress, kids who are gifted, kids with sensory issues. So we need to be careful to make a diagnosis, get the right diagnosis from the start, and to reconsider a diagnosis when things seem to be evolving to indicate that there's much more going on.
Which brings me to something that really frustrates me about this whole topic. The guidelines indicate that we should review report cards and look at teacher evaluations and give ADHD screening questionnaires and gather education evaluations from the school. But even with the extra training most of us have taken advantage of in this area, pediatricians are not educational specialists.
We're not.
And there are often very limited resources in the public schools and in some of the private schools, particularly the parochial schools, and even more so with the current COVID pandemic. And the schools will never, at least I've never seen, ever make a cold diagnosis of ADHD.
Never. And we strive to be complete pediatricians. We're both lifelong learners. We want to constantly continue to add to our skills and our fund of knowledge. But we're not educational specialists. I want someone well-versed in all the different diagnostic educational screening tools, and we only mentioned a few of them here, and to tease out the learning and the attention and the anxiety factors in a full psychoeducational evaluation, including direct observation of a child in school if needed. And I don't want to cut corners for these kids.
This could be done. I mean, our educational system, by all accounts, is antiquated and largely counterproductive. It's aimed at the lowest common denominator of achievement. Sorry, man, you got me going here now.
I know.
Which confuses those who need more assistance or maybe best encouraged to focus on mastering radically different skill sets than what's being taught so that they can be engaged and successful and employable. And I'm not talking about, hey, listen, you aren't capable of this, you aren't capable of that. I'm trying to discern what are your strengths, and how do we play off your strengths? And as any, I think, psychoeducational specialist or any, to be honest with you, any business owner or person who knows anything about how the world works, your strengths is where one should focus more often than not, as long as your weaknesses aren't debilitating, right? And so, golly, we're all made up differently. But what I see happening is with it being aimed at the lowest common denominator, it also frustrates and boards those who want to engage at higher levels of thinking and problem solving. And again, this isn't to say that we should prioritize any group in our efforts. There's a place for nearly everyone to be productive and content in our society. But to discern the areas in which each student, requires assistance, encouragement, or direction really seems like it would be a good idea, right? It makes sense. It would not come cheaply, but this is the same country that put a man on the moon. And I know that sounds cliche, but for God's sakes, like maybe we buy one fewer $800 toilet for the military and we start investing in things like this. What could be a greater investment than in moving logically and scientifically toward optimizing every student's future by identifying what they need to learn best and under what conditions they can thrive?
Our job in this area as pediatricians is to identify at-risk kids and to help families get the best evaluation available to them from a practical standpoint, and then to help them find therapy or executive function coaching, and yes, to discuss and perhaps prescribe medications that could assist with attention. But going to what you said, Matt, investing, figuring out what the strengths are and the weaknesses early, in my perfect world, every 5th or 6th grader in the country would get a full psychoeducational evaluation across the board in order to discern how they can best learn, and then provide teachers, families, and even tutors with pertinent resources to achieve optimal learning opportunities. I think that would avoid lots of frustration and lots of school failures. And honestly, it's the kids with means. It's the rich families that get the full psychoeducational evaluations, and they do it privately. And everyone else is left to fend for themselves and fall through the cracks or only get looked at if they're failing. And I think it's atrocious, and that's where we should be putting money into. Let's look at how these kids learn, how their brains are, their strengths and weaknesses, not just test them and then pick up the pieces later and see who failed and who didn't.
But that will not happen. None of these things will happen anytime soon. So we have a child who's reported to have attention issues, and then we get information from screens like the Vanderbilt form, and then we do an exam and make sure that hearing and vision are normal, and screen for anxiety and depression and sleep issues and even more. And we often try to get the school to do at least some type of an educational evaluation, which is tough to get done unless the child is already doing poorly, and especially tough to get done if the child is older or if they're getting decent grades, but seem capable of more. If the school does complete an evaluation, it often is not a very thorough one and never will make a diagnosis of ADHD. At most, the report may say that there is a concern for attention or that there is a processing speed deficit, and then punt it back to us. It's important to know that even if a child is in private school, a child is entitled to whatever evaluations are offered through the public school system. When we're unable to get a complete and thorough evaluation through the school system, we will suggest the option of having a psychoeducational specialist in private practice do an evaluation. It's often a challenge, though, for families with limited means, and many of our families are of limited means. These types of evaluations are done outside of the school district and are quite expensive for some families, especially when times are tough. Now, we often try to find someone to do a psychoeducational evaluation that a family can afford, and we both know some psychologists who will do an evaluation with a sliding scale payment to make it more achievable. I do point out that although several $1,000s is a great deal of money, it's also cost effective in terms of investing in the long run. The reality is that some families simply can't afford it, and the insurers rarely cover it. So sometimes we must cut corners and treat a child based on less than ideal information. More often, that treatment is with a stimulant medication.
And in my opinion, psychiatrists and neurologists really don't seem to handle the prescribing of these types of medications any better than an informed and experienced pediatrician. Over the years, I've had what I think are pretty complicated kids with focus concerns that after one session with a psychiatrist or neurologist with no further evaluations or testing, aside from some rating scales and an interview, they come out with a script for a stimulant after 30 to 40 minutes. Have you seen that, Matt?
I have, and I always thought, wow, these guys are much smarter than I am on this topic. But when truth be told, over the years, as you discuss with parents what that evaluation consisted of, oftentimes it's a pretty casual, just a conversation. You know?
Right.
And admittedly, I mean, sometimes these guys are on the mark, but you would just hope for a more thorough overview.
Right. So back to the AP guidelines and the key action statements about treating children. Make no mistake, it's important to treat these children for a wide variety of reasons. Aside from the academic and behavioral struggles, which often result in low educational achievement in an untreated child with ADHD, those with untreated ADHD, which we said before is like a third of them in the United States, are statistically at significantly higher risk for incarceration, for substance abuse, and for death by suicide. So for preschool children, ages 4 to 6, who are diagnosed with ADHD, the strong recommendation is to have them go through Parent Training Behavioral Management, or PTBM, first. Sometimes the school will have a therapist who can help us with it. It must be a therapist who's used to young kids. And it's hard to find someone who's good, and it's generally, again, not covered by health insurance. These younger kids are usually the hyperactive Dennis the Menace type presentations, and they're memorable. If this type of behavioral program is not available or not working, then the next type of management would be a trial of methylphenidate. Have you prescribed methylphenidate, the Ritalin type medications, to 4 to 6-year-olds much in your career, Matt?
I've prescribed it, but not much. It really has to be a pretty dramatic situation. Oftentimes, when I am looking to prescribe any type of medicine or consider it with whether it be any type of a neurobehavioral issue, I want 3 questions asked. I want to know, A, is this behavior affecting the child's academic performance? B, is this type of behavior affecting their social interactions with their peers or with others in the community? And C, is this behavior making your family work differently than you want it to work, from the standpoint of it's just so disruptive that everybody feels like they're either walking on eggshells or constantly yelling at each other? And when you can meet any one of those 3 criteria, it's at least worth discussing.
Right. Especially that parent one and the siblings. I mean, this is the brothers and sisters are suffering a lot too. So I don't do it. I haven't done it much, but there have been occasions I've done it. And I will say, we talked about psychiatrists and neurologists, I'd rather them do it in some ways, or developmental pediatricians. So I've had them do it, and they right away will write something. And maybe we should think of it more, but it's rare. We're not looking to start attention stimulant medication on 4 to 6-year-old, if possible.
Okay, for the elementary and middle school children, ages 6 to about 12, the recommendation is to prescribe FDA-approved first-line medications, and also to suggest or to try the PTBM and classroom behavioral interventions. The plan can also include an IEP, or Individualized Education Plan, to address learning goals, and a more comprehensive plan called a 504 plan, which usually provides extra accommodations specific to the diagnosis of ADHD, including providing the student with extra time for testing or assignments and preferential seating in the classroom. These days, with school homework portals and such, it can also be helpful to have the assignments posted so the parents know what the student is supposed to be doing and can help them organize their work, because often these children have limitations in their executive functioning. Private schools are not always required to offer formal 504s and IEPs, but in my opinion, they have increasingly been doing great work accommodating children with these issues, like allowing the child to stand at his desk and shortening the length and duration of worksheets.
Now, for adolescents aged 12 to 18 and beyond, the AP recommendation is, again, start with medication. Behavioral interventions and strategies are also encouraged, if available. Specifically, there are some executive function coaches out there that work with high school kids, and that could be helpful. So it's appropriate to usually start with stimulant medication, or perhaps the non-stimulants, for these older kids and teenagers, which gets us back to the world of ADD medications, Matt.
I think this is probably a good time for us to stop this episode, and with the next episode, we will be moving right into the discussion of ADHD medications, and so we'll talk about that a little bit next time when
Absolutely.
we talk about meds.
Okay, say goodnight, Matt.
Good night, Rob.
Good night, Moon. Podcast Nutrition's Productions. All rights reserved.